our third objective here is to explain the control of water balance and osmolarity by antidiuretic hormone, ADH, also called vasopressin. Um, let's begin by thinking about our various water states. We're going to talk about osmolarity and things like hypovolemia, hypervolemia, normovolemia, so different water states, and the movement of water. We'll also talk about water reabsorption. It happens at different places along the tubules. It happens sort of unregulated and uncontrolled in the proximal tubule, and then it happens more in a regulated way in the later parts of the tubule, including the distal tubule and the collecting duct under the influence of hormones. Now, in the middle of the tubule, along the loop of Henle, we have the reabsorption because of the medullary osmotic gradient. So it happens at different stages of the tubule through different mechanisms and, with different players involved. So we'll talk about all of the different ways that water is reabsorbed. So let's remind ourselves about the water balance. So in terms of water intake, this is what is coming in through our diet, what is released because of cellular metabolism. So breaking down of biomolecules can release some water. And so that is our water input. That is about 2.5 liters per day in terms of various sources of water through the diet, through the ingestion, etc. Now, if you think about our outputs, this is going to be insensible loss, which means water loss through heat, through sweating, again, as a byproduct of metabolic use of biomolecules. It also happens through the gastrointestinal tract and is released in the form of feces that is excreted about 0.1 liters per day of water excreted along with feces. And then through the kidneys, about 1.5 liters a day excreted through urine. So several different mechanisms for excreting water or water output or water loss. However, it should be equal. For homeostasis, for good water balance, for proper hydration, we should have our total input, which is about 2.5, equal our total output, also about 2.5 through those various sources. And looking closer at this, we can see how those different mechanisms of, the inputs are processed differently that lead to different outputs. So the ingestion is the majority of our input, again, through our diet. This can be directly through water intake, but also indirectly through foods, etc. And so that is absorbed in the gastrointestinal tract, and that is equating to about 42 liters per day through absorption. And then some of that is also going to be secreted to result in excretion, which happens through feces. On the other end, in terms of the tubular loss that happens in the kidneys, we also have filtration of that plasma, resulting into some of that fluid, secretion of things that not initially filtered, resulting into some more of that fluid, and then the reabsorption is going to take some of that away. So we can sort of subtract anything that is reabsorbed. That results in about 1.5 liters per day. And then a lot of what is processed metabolically. So through cellular metabolism, it's a small amount, but that is going to sort of be contributing to our what we call insensible loss, right? Sweating, loss of heat through thermogenics, etc., is going to be a smaller amount at 0.9 liters per day. So different mechanisms resulting in input versus output, and then how the kidneys can be involved in sort of regulating that, secreting some things, reabsorbing in some areas as well. Let's talk about our different water balance states. So normovolemia, having a normal blood volume, which in our previous scenario means that our intake is pretty equal to our outputs. In terms of hypervolemia, this is where we have a high blood volume to positive water balance. This is where our inputs are not being met by our outputs. This can be just excessive water ingestion. And then hypovolemia, low blood volume, or a negative water balance. This can be states like dehydration, volume loss through bleeding, etc. So hypervolemia, excess water, excess volume, or positive water balance. hypovolemia, low blood volume, in other words, low water, and that would be a negative water balance. Now let's talk a bit about here osmosis. So water diffusion down its concentration gradient. This we described as being the principles of osmosis. Water is going to move down its own gradient, its concentration gradient, but it also moves against the solute concentration gradient. So water moves from a place of low solute concentration to high solute concentration, working against that solute concentration gradient. And so if we think about that, that basic principle of osmosis, it's going to be the reason to explain why we see water move in different parts of the tubules. So water reabsorption is simply going to follow solute reabsorption. We discussed this a bit briefly when we talked about the reabsorption happening in the proximal convoluted tubule. So we moved sodium across that membrane actively. We moved chloride also, according to that gradient. And then because of the solute gradient created, water can simply follow by osmosis. So this can be somewhat of a hack or a trick that the body uses, a mechanism. It simply moves solute and then water follows. Okay, we'll see that quite a bit in the different areas that it is absorbed. Now, in terms of thinking about the osmolarity of body fluids, it's about 300 milliosmoles. And so the solute in our proximal tubule, so at this part of our tubule, is pretty isoosmotic when you think about it compared to plasma. It's about 300 milliosmoles, and it's going to be comparable to the osmolarity of our plasma. And so in these parts of the tubule, there's no osmotic force in order to move water because of the isoosmotic state, right? There's no gradient, so there's no flow. The kidneys, however, can begin to compensate for that by moving solutes around, so they can move solutes around to create the gradient that will then allow the reabsorption of water. So the kidneys, again, very smart, very efficient in that way, where they create a solute gradient first, and then water simply follows. Because water movement is a passive process. It's based on the osmotic gradient. It's based on the concentration of water from high to low, or the concentration of solutes from low to high. So as soon as we have established a solute gradient, we have established the basis for water movement. And I just want to begin to describe what's happening here. So here's our tubule, proximal convoluted tubule, our loop of Henle, starting with the descending limb of that loop. This is permeable to water only. No solutes can move across the descending limb. It's impermeable to transport of sodium, potassium, urea, other solutes. The ascending limb is the opposite. It's impermeable to water, but it is permeable to all of those solutes. Sodium, potassium, chloride, co-transporters exist on the surface of this membrane, so those solutes can move across on the ascending limb. And so what we'll see is that the solute movement happening on the ascending limb creates the gradient for the water to move on the descending limb. So when we create that salty environment, notice how the osmolarity of our peritubular fluid and our interstitial fluid around the tubules is increasing as we go from uh, the, uh, the proximal parts of the loop of Henle down into the distal parts of the loop of Henle, that osmolarity increases. So down here, because we have moved the solutes into this area, we now have a gradient where water can simply flow on the descending limb by osmosis. The mechanism for moving water in the proximal convoluted tubule is slightly different. We'll talk about that, but that is also the similar mechanism where solutes move first and then water follows by osmosis. The mechanisms in the distal tubule and the collecting duct are also slightly different. This has to do with certain water transporters, which we call aquaporins, and hormones and other other regulatory substances that have a controlled mechanism for reabsorption. So in the proximal loop of Henle, it's unregulated, uncontrolled. In the distal tubule and collecting duct, it is very much regulated by hormones such as antidiuretic hormone. Let's begin by thinking about the proximal tubules. So the proximal tubules, 70% of water is reabsorbed here. It is unregulated, uncontrolled. It happens freely as long as the gradient exists. So that is going to be where most of our filtered water is going to be absorbed in that proximal convoluted tubule. The distal convoluted tubule and the collecting duct, again, this portion is regulated reabsorption. It happens by way of antidiuretic hormone, which triggers the insertion of water channels. We talked about these channels earlier that only allow the passage of water. These are called aquaporins. So antidiuretic hormone can trigger the insertion of more aquaporins into various parts of the distal convoluted tubule and the collecting duct, and that can facilitate the regulated reabsorption of water in those later parts of the tubule. So recapping the mechanism here for proximal tubule reabsorption of water, this is going to facilitate sodium being actively transported across that basolateral membrane. The sodium-potassium pump is important here. Chloride being passively transported in conjunction with that sodium, and then that creates a solute gradient as the solutes move into the peritubular fluid and then into the capillary, and then water can simply follow with the osmotic gradient that is created. All right, so this mechanism explains, again, 70% of the water being reabsorbed and unregulated reabsorption of the water in this part of the tubule. So recapping that mechanism, sodium can move into the cell passively because of a co-transporter with glucose moving actively. It can move across the basolateral surface actively, right? It's being pumped with the sodium-potassium pump, and then it can be passively reabsorbed into the plasma across that capillary endothelial cell. So if we think about the solutes moving first, so solutes such as sodium, and then solute X, for example, this can be chloride, solute Y being another example, or sorry, solute Y is going to be more be chloride, which is moving passively. And then solute X will be another substance that is being secreted across that membrane. All of these solutes will be reabsorbed into the plasma. And then on the other end, water can move by osmosis. And then any other permeating solutes that can freely move will also be reabsorbed. Now we're going to get into the establishment of the medullary osmotic gradient. I began speaking about this gradient a little bit earlier. The difference in the medullary osmolarity, so the osmolarity in the upper parts of the medulla versus the lower parts of the medulla. And we want to remind ourselves here that the cortex is where we have the renal corpuscles. The cortex is where we find the proximal convoluted tubules, the distal convoluted tubules. The medulla, which is the inner, darker appearing region of the kidney, is where the loops of Henle dip. They dip down into the medulla of the kidney, and then the ascending limb comes back up towards the cortex. So this is why we describe this as the medullary osmotic gradient. It's the gradient occurring as the fluid travels deep into the medulla of the kidney. Now we're going to find a lower osmolarity near the cortex, so about 300 milliosmoles, which is similar to what we have in our tubular fluid. So it's going to be isoosmotic here, therefore no transport across that tubule. If we think about the greater osmolarity, so the osmolarity increases as we get down near the renal pelvis, so deeper into the medulla, we see a larger osmolarity. That creates a gradient. And this gradient is going to be crucial to the reabsorption of water that happens across the kidneys and is going to be more associated with the medulla of the kidney. Okay, now we're going to go on to describe how this mechanism is set up, but the overall premise is our solutes, the solutes that are being actively pumped across the ascending limb of the loop of Henle. These are what create this extremely salty, I like to use this word salty, just because it has a very high osmolarity, it's almost zero water and majority solutes. So this creates that extremely high osmolarity the lower we go into the medulla because of these solutes that are sort of reabsorbed across the ascending limb. And then in the descending limb, we're going to have water being reabsorbed, as the descending limb is only permeable to water. The ascending limb is only permeable to solids. All right. Now, in order for us to establish this osmotic gradient, we need to think about the counter current multiplier. This is dependent upon the loop of Henle, the what we just described a minute ago. So the ascending limb being impermeable to water, but permeable to solutes such as sodium chloride, potassium. The descending limb being impermeable to solutes, but permeable to water. So that is what we describe as the counter current. Countercurrent just means that both limbs are moving different substances in different directions. Ascending limb moving solutes, descending limb moving water. That mechanism is what establishes that osmotic gradient. That is why the osmolarity gets higher the lower into the medulla meco. Right. So here is our filtrate. It's starting with an osmolarity of 300. As it moves down the descending limb, the osmolarity gets greater because we're losing water, right? We go from 300 to 600 to 800 to 1,000 to about 12 to 1,400 down here in the dip of the loop of Henle. That is because we're losing water. We're losing water only being reabsorbed into the capillary along the descending limb. So what's left back is extremely saturated, concentrated, and a higher osmolarity. As we move in the opposite direction, the opposite is true. We're now moving solutes through these co-transporters, moving sodium, potassium chloride. And now, because we're not moving water, the osmolarity is going in the reverse direction. We're going a lower osmolarity to 1,000 milliosmoles, 800, 600, eventually lower up here in the distal convoluted tubule. So our filtrate at the end of the limb of the loop of Henle has a lower osmolarity than what we began with. It's now about 100 milliosmoles, whereas we began with about 300 being the osmolarity. So that is a result of, again, this mechanism. It is allowing the reabsorption of both solutes and water at different places in the limb. And then our solute, our final filtrate at the end of this loop is going to be lower than what we began with. So in the descending limb, the osmolarity is equal to that of the interstitial fluid. All right. In the ascending limb, the osmolarity is going to be less than that of the interstitial fluid, right? It's going to be lower than what we started with. So what do we end up with at the end of that mechanism? So we have fluid in the distal tubule being lower than what we began with. So it started at 300 milliosmoles in the cortex, and then in the distal tubule, it's going to be about 100 milliosmoles. We also end up seeing that the interstitial fluid of the medulla, the osmolarity there is increasing from the cortex, down to the pelvis. So that is another, um, you know, um, sort of scenario that we see when we think about the changes as a result of that countercurrent multiplier mechanism. We end up changing the osmolarity of not only the filtrate in the fluid, but the interstitial fluid surrounding the tubules as we go from the cortex to the medulla. So just to reiterate that, we're changing the osmolarity of this fluid here. It's much lower in this end than it was when we began. We're also changing the osmolarity of the fluid that is surrounding the tubules or the interstitial fluid, that is being reabsorbed into the capillaries.